All right, thanks everybody for rejoining. Thanks to everybody who's online. I'm Sarah. You might have heard me once before, or twice, you poor things. And I'll be your moderator for this afternoon's session for the next part of the programming. Now, I do apologise in advance if I butcher anybody's names. I have been practising. However, my French pronunciation is fairly average. So, in no uncertain terms, I'd like to start off. I'd like to welcome Marcela Santos for Closing the Gap, Quality of Life Through Assistive Technology.
Hello, everybody. I have the worst time because everybody will fall asleep if I don't talk really funny or make you laugh. I hope you had a great lunch. I'm Marcela Santos. As you may know, I'm the one that asks a lot of questions. I'm a very curious woman. I'm also a psychologist, but most importantly, I was a child caregiver for my dad who had ALS for 16 years. He already passed 3 years ago, but to answer Melinda's question, we don't know what happens to kids after they're caregivers. You could be here presenting in the APF worldwide and be in the board of directors of the International Alliance of ALS-MND. Here? Okay. So today I'm going to be talking to you about how we close the gap. And it's something that we were talking about in the discussion is how do we close that gap? How do we get assisted technology and AAC to people and regions where we don't have them, like, for example, Colombia, where I'm from. This is Felipe Ocampo. You may know him as our PALS. He's also part of the PCAC in the Alliance, and he's also a doctor. So in honor to him, this is his photo. And later, you can ask for my data because you're going to need them with the homework I'm going to give you. About ACELA, it's a nonprofit in Colombia. We are all volunteers of caregivers of patients with ALS or patients with ALS. Our mission is to promote the quality of life and well-being of all the patients with ALS and their caregivers. We were founded in 2008, and we are members of the Alliance since 2010. We have 23 permanent volunteers. Colombia has a population in South America, very important, has a population of 51.52 million people. Of those, there is an estimated 3,000 patients in Colombia. In their health registry, we have a registry when the doctors do a diagnosis, we have 1,525. In ACELA, since 2021, when we started counting how many people have reached us, 534 patients. So you see there's a sub-registry, and there's only a few people that have able to contact us. However, we have done a lot in that time. A little bit of context in Colombia, almost 95% of Colombia has a health insurance. We are covered mostly. 54.8% of the population belong to a subsidized regime, which means they don't have to pay anything to get health care, and they get the same benefits as the people that are in the contributive regime, which is the people that pay a monthly payment, and they also pay a copay whenever they access anything in the system. They have the same package of health benefits. It's important that you know that, because independently of if you're living in a very poor region or in a very with higher economic status, you can access the same package. That means the multidisciplinary team treatment for ALS, physiotherapy, speech therapist, neurologist, all the appointments, anything you need, it is covered by the health system in Colombia. However, eye gaze and voice banking, among other augmentative communication methods, are not covered by that health benefits package. So when a medical treatment or device is not included in the mandatory health package in Colombia, doctors must request it, especially through a platform called MIPRES, and they must justify it. This patient needs this. So this is what happens when someone needs eye gaze in Colombia. Normally, the insurance company says, you know what, we're not gonna pay that. Like, it's a no from us. So in Colombia, there's a legal action called tutela, which basically is a legal medium where we can access our rights, we can demand our rights, and patients have gotten this eye gaze communication device through that. However, speech therapists in Colombia know little about ALS, and they know even less about voice banking, eye gaze, and all the alternative methods, more than the board, as you see in that photo. That is my dad. he's saying, let me see. I'm writing. Oh, this was his last day before he died. He said, "I'm writing. Just remember the good times we have when you were our children. So when we were kids." So this was my dad's communication method, and it's the most common, the one we use in Colombia. We are prepared in case of an emergency and a power outage. We will be able to communicate with our patients because this doesn't need a battery. This doesn't run off. The only problem with a communication board like this is that you need to learn how to use it in order to interpret the patient's communication. This makes it a problem for a patient that wants to talk. For example, if my dad had to complain about the nurse, he would have to do it through her. You know, so it makes it very uncomfortable. He had to have a conversation with my mom about their marriage situation, about something emotional. The nurse was in there. The nurse was part of that communication. So how do we close that gap? How do we make it better for our patients in Colombia? In Acela, we do legal support. We did a strategic alliance with a university, and they offer free legal support so patients can access these eye gaze communication devices. However, it takes time, it takes effort, and we were thinking, okay, what's the situation in Colombia besides that? How's the voice banking? And I had an amazing conversation with John Costello earlier. We're gonna work together. In 2021, the Alliance made a fundamental rights survey, and they gave us, well, all the countries that participated gave us a specific report. These are the results of our survey. We had 112 responses. It was the second country with most responses, and if Jess corrects me, I think this year we were also in the top 3 countries that responded the most. We are a very small association, but we're small but mighty. Of that, 112 responses, 23% were PALS and 77 were CALS. 50% saw a speech therapist. Speech therapists in Colombia only help PALS with maintaining their voice the most they can, and the boards that you saw. That's it. That's the general rule in Colombia. They don't do what you all amazing speech therapists and pathologists do worldwide. So how do we change that? Only 13% received any communication support, and there's a 0% voice banking, are not even near diagnosis, like ever. So being part of the Alliance, not because I'm a board member, but really has been the greatest experience in my life. And it's because I've met people like you, and in conversations having with them, I noticed, yeah, I go to these meetings that we don't have that in Colombia. We don't have that in Colombia. And I got this from my dad. I'm really stubborn. And so I say that I'm not going to take a no. I have to take a yes. So in one of the first meetings, I remember we talked with Evie from Belgium, and they said, we can donate electrical wheelchairs to you guys. So I said, okay, let's do it. They're used, but they're in a really good state because we change them every couple of years to a patient. So I was like, okay. And I'm talking really fast because I know time is running. But okay. So I had a friend in a company that did importations. They were willing to pay for the 50 wheelchairs to get transported from Belgium to Colombia. So I said, okay, we got the most expensive thing we got, which is a wheelchair, and then we got the transportation. And we talked to the FDA basically in Colombia, which is called INVIMA, and they said, you know what, donations of wheelchair and medical devices, they have to be new, they cannot be used. And it's like, oh, we're really good at getting new laws like in the US, but then we're bad at making it accessible for our country. So we could not get that wheelchair donation. But then, again, amazing Alliance team. I was in a conversation once, and they said, with ALS Association, they say, we have a lot of obsolete equipment of eye gaze devices that we have to let them out, or I don't know, not kill them, but you know what I mean? Like, basically throw them in the trash. And I'm like, wait, what? You have Tobii eye gaze devices that are worth 60 million pesos in Colombia, which is a lot of money, and you're just gonna throw them in the trash? Give them to me. I said, sure. I said, wait, what? Kalanit said, send me an email. I was like, okay. I sent an email. I said, Kalanit, you told me to write you, I'm writing. Do you have devices? She immediately sent me to one of her chapters in Sacramento, and she said, I said, I'm going to the US. I'm traveling by plane. I'm taking a suitcase. I can bring some with me. When I get to Sacramento, 17 devices were waiting for me. So the ALS Association, not only the chapter gave me some, they united all the eye gaze devices they had in California. They were about to put in the trash, and they collected it and they gave it to us. Gorijan showing the way. So that's where we did the partnership. And then comes the problem, how do I get them to Colombia? Because they're not new, right? And it's a medical device. So that's when you start thinking about who your friends are. And, and I had another friend that does importations in Colombia, shipments, and when you need to buy a computer or house things. And I told him, we need to get that in Colombia. Like, I can only take 6 in my bag. My mom can take 6, but we still have more that we need to send to Colombia. And he said, show me a photo of what you're bringing. I said, it's a computer, basically. He said, I don't need to put it's a medical device. I'll just say it's a computer. It's a home device. I was like, that's a great idea. So this was the solution that we managed to have. Fortunately, we had no problem. This is actually a photo I took on the flight because it was beautiful. And I said, we are doing this. I mean, I hope I don't get any problem. Like when I get inside the country, they're going to ask me, why are you bringing 6 computers? Fortunately, they were different. There's a law in Colombia that you can bring 5 products of the same, 5 things of the same product. Fortunately, they were different Tobii Dynavox, so I didn't have 5, more than 5, so it was great. And here it is when we received 17, actually, the first time we received them. Ta-da! So thanks to that alliance and the ALS Association's generous donation, we have actually done this twice. We have more than 20 devices at no cost. We are closing the gap, guys. And this is the most important message that I want to leave you. There's no reason why everybody in the world should get the best treatment possible or the best technology possible when we can work around the rules that are telling us we can't. And yes, we can. So we have amazing testimonies of patients that are now communicating that had stopped talking for years, and they are now saying what they want, what they don't want. They are even writing a book. I have a patient that wrote a book with the eye gaze device that he got. So this is actually our president, Orlando, which you saw in the inaugurational video. He was the one that talked at last of the video. And now he uses a Tobii device so he can talk to anybody. And he's in the PCAC as well and in the ITAC project we're doing. We have given them back their ability to communicate, their identity, their liberty, and their independence. As I said, we're small but mighty. And Colombia, although we are very small, if you have been in the meetings these 4 days, we've been mentioned at least once a day. Not just because I ask a lot of questions, but really, we are trying to get in every project there is worldwide. So if you have any obsolete devices that you want to donate, because there's a long waiting list of more than 40 patients in Colombia. And if you have obsolete eye gaze devices or similar AAC, come to me. I'll help you with that. I mean, I can travel to where you guys are, and I can bring that back to Colombia. And this is one of the examples of the ITAC. We're actually the first country to start a pilot with the ITAC in doing voice banking accessible for everybody worldwide in a easy, accessible, and hopefully free manner worldwide. So I just want to close with, in order to close the gap, we need to engage in collective action. We need to seek cost-effective solutions. Think outside the box. Don't stay with the no. Think outside the box, please. Do it for your patients. Do it for their quality of life. Do it for their caregivers and for their families. And advocate for policy changes. Thank you so much.
Oh my goodness, thank you. Thank you, thank you. And just for the record, Sarah said I spoke fast.
I did my best. I
You were
swear
brilliant.
I did my best.
You were brilliant. And I think, from the session before, where I was also talking about that, what keeps you up at night? Where are the gaps? This is an absolutely miraculous example of passion that closed a gap, and I absolutely take my hat off to you. And we have some time. We have a couple of questions if anyone has a question.
I finished early, by the way.
Yeah, I know, you did. Look at that. Look, I even had the timer going. You've got 33 seconds.
Sarah has a question.
Of course I have a question for you, Marcella. I figured since you weren't out here to ask a question.
Thank you.
So you said the speech therapists aren't trained in it. So who's doing the training then for the people using the devices?
That's a very good question, which I forgot to mention. We actually talked to the person that imports Tobii devices in Colombia, which he actually sells it to insurance companies when they are actually obliged to. And we came to an agreement with him, and he would charge 100,000 pesos, which is $25, to train a patient on the device. It's a special price he's giving our patient. So we're not actually buying the devices from him, but he is so in touch with what we do that he's a strategic alliance for us, and the patients that get the devices at no cost. So how does it work? We loan the device free of cost with the condition that when they're done using it, they will return it to Acela and we will give it to the next in line. So that's how we do it. We train, the Tobii guy trains our patients. And there is one speech pathologist in Colombia that does that, but she's in an insurance in a clinic, so it's not accessible nationwide. But yeah.
Is there any other questions? Oh, one up the back there.
Hey, Marcella.
Hi.
Just not a question, because we built this relationship together. I just want to make a comment that because of what we did together, our relationship in the United States with the association and Tobii has gotten even stronger. So when they realized that this was a way or potential opportunity, maybe coloring outside the lines a little bit, I think it actually has strengthened the association's relationship, which then I think will allow us to do even more. So I want to say thank you for that.
Thank you.
Well, one more question just down here. I think this will be the last one.
Hi, it might not necessarily be a question for you, Marcella. I might be a very simple soul, but I have to question, how can it ever be right for any equipment that is functional to be thrown away?
Beats me.
I don't think any of us, none of us are arguing with you.
Yeah.
No, but there must be a way somehow of actually, raising the issue, other than Marcella. Yeah, but actually flagging it up that in today's world, if nothing else, that's criminal.
Well, certainly in Australia, we have options to send stuff to Papua New Guinea, to the Pacific Islands. So, I mean, that's just because they're geographically close to us.
Yeah.
And our Tobii company in Australia supports devices in the Cook Islands now, and Papua New Guinea.
So if you have obsolete IA's communication devices, please contact me. I'm wearing an orange shirt. You cannot miss me. And please let me know if you need help getting rid of those. We will take them. Thank you so much.
Amazing. Thank you so much, Marcella. Up next, we have Healthy Teeth and Proper Oral Health from Michael van der Linden, which might be online.
With my colleagues Maurits van Selms and Connie van der Meijden, I'm very honored to speak to this audience of the International Alliance and the ALS and NMD community. We'd like to thank the APF organization for giving us this opportunity. Oral hygiene. Why is that so important for people who suffer from ALS? It might seem obvious, since generally speaking, oral hygiene is important for all of us. Preventing caries and periodontal disease, that's disease of the gums and jawbone, well, the importance of that goes without saying. And furthermore, there's high quality evidence to support a likely association between oral health and cardiovascular disease, and between oral health and respiratory disease and others. Why is it even more important for patients with ALS to have good oral hygiene? If patients with ALS need respiratory support and tracheostomy, this may have a profound effect on the oral cavity. Patients with ALS who need mechanical ventilation may be at an increased risk of developing pneumonia, which may be life-threatening. So, paying attention to oral hygiene in ALS is important. In the case of tube feeding, however, daily oral hygiene may not always be taken into account. This may be due to resistance feelings among caregivers due to bad breath, for example, or danger of choking. In advanced ALS, it may be almost impossible to perform dental procedures such as restorations. So how to maintain this good oral hygiene? Well, the general guidelines on this look very simple. First, brush your teeth twice a day, do it for 2 minutes. Please do not forget those spaces between the teeth. Well, this is harder than it seems. We know the arm-hand function of patients with ALS may be poor or absent. The second guideline, limit your daily eating and drinking moments to at most 7 times a day. Is this hard to do? Well, actually for ALS patients it is. They need to eat and drink more often to ensure sufficient calorie intake. The third general guideline, please see your dentist regularly, is not at all that easy. Most dental practices are just not accessible to patients with ALS, if only for the design of the surgery rooms, chairs, etc. So the general guidelines hardly apply to our specific group. To investigate the problems that patients with ALS, their partners and their caregivers experience when performing daily oral care, we performed an exploratory study at ACTA in 2022. It followed a qualitative design with semi-structured interviews and video observations. Together with 2 students, we investigated 6 patients with ALS at their homes, 4 partners and 2 caregivers. This study was published in a Dutch language journal in 2023 with support from VU-Vereniging, a non-profit organization. What these interviews showed in general was that the performance of oral care is hampered by the loss of motor skills and by the gag reflex. Patients, specifically, expressed dependency on others for daily self-care. If a visit to a dentist was possible at all, patients emphasized a need for adaptations in the surgery, accessibility to a wheelchair, adaptations to the dentist's chair. And if the dentist or oral hygienist would use large amounts of water or aerosol, this would lead to gagging and discomfort. In general, patients felt dissatisfied with care. Partners and informal caregivers used various ways to help the partner or the patient with brushing and interdental cleaning. However, 2 partners sometimes felt unsure whether they were carrying out oral care in the proper way. And their oral care abilities had been learned in the past from their own dentist, from an oral hygienist, or from home. They expressed a clear need for professional instruction. 3 out of 4 partners indicated that an instructional video may offer added value. Professional caregivers, often the general practice nurse, provided active help with brushing and with interdental cleaning. They too expressed a need for training, for example, by an instruction movie. The video observations show that techniques varied across patients and caregivers. Sometimes too much force was used when brushing the teeth, as indicated by the electronic toothbrushes indicator lights. Often, brushing was too short, for example 1 minute. Sometimes only the buccal surfaces at the side of the mouth were brushed, and if the lingual surfaces in the middle were brushed, this could result in gagging. What this pilot study shows us thus far is that there's not one single way to perform daily oral care for ALS patients. It's important to be adaptive, to perform oral care according to the wishes and limitations of the patient. Training is required For example, instruction videos of pamphlets may be useful. And knowing how to properly perform oral care on someone else makes it easier to do it under the changing circumstances and during progression of the disease. So far, the conclusions of this exploratory study. How to follow that up? Well, more research into these obstacles may contribute to the quality of life of patients with ALS. Caregivers should be empowered to provide this care with confidence. The results from the exploratory study could be substantiated in a larger study. Results should be disseminated into the international scientific community. The results should provide input to develop clinical and practice guidelines on how to provide daily oral care and self-care. An instructional video could be developed as part of these initiatives. Also, an e-module could prove to be a valuable instruction tool for partners and informal caregivers. Apart from research, what else has been done in the Netherlands on this? Well, the ALS Center, a knowledge platform by professionals and patients, has developed information for patients, relatives and healthcare providers. The ALS Patient Association also provided patient and relatives information by their website and also by information in newsletters. So what I would like you to take home from this is oral care and self-care for patients with ALS just need a bit of extra attention. Thank you very much.
Thank you, Michael. That was amazing. We've got time for a couple of questions. That was a bit of a shorter presentation, so if anyone's got any questions, pop your hand up, or anyone online. Oh, there's one there, over to my left.
Okay.
Hello, I'm David. I'm a patient fellow from California. I'm curious if there's advice for those like me who have ALS but are still able to take care of my own oral health. And as it changes, are there things that we should be considering doing differently that will help us have better results if and when it becomes necessary for other people to help us out?
Yeah, thank you very much. David Wallace? Yes. Thank you. So if you happen to have ALS yourself, which is of course unfortunate, it still is, it's even more unfortunate if you're not familiar with the daily oral self-care routine. And what this study showed us was that patients, but informal caregivers and partners of patients are often just without a clue of how to do it. And I would say the one important thing is to avoid risks, such as risk of gagging, or even or discomfort, or even risks of suffocating by using too much water. So this is one example of a problem or risk that arises from daily self-care or oral care by others who are just not familiar with ALS. The other thing is if you brush your teeth, or if your partner brushes your teeth, to pay attention and not to brush too forcefully, but to use moderate force and not to pay attention to all the teeth and the entire surface of your teeth. Some caregivers just rush over the daily routine, whereas others just spend a little bit of time for each and every teeth. Is this a kind of answer to your question?
Yes, thank you.
Right.
Is there any other question? You've got one online?
It's not really a question, it's a comment from a couple of people chiming in what they utilize. One said that they use a non-foaming toothpaste, and another uses an antibacterial mouthwash, and I didn't know if that had been addressed.
Well, this was a small study with only a couple of patients and their caregivers, so there were no special measures being investigated. We have received a small stipendium from the Dutch Oral Medicine Society, or Medical Dental Interaction, it's also called, to further investigate issues. And the use of non-foaming toothpaste is a very interesting possibility. What was the other one you mentioned?
It was an antibacterial wash. And then another person just chimed in again and said a child's small toothbrush as well, they found to be successful. So it's all these wee hacks, and it sounds like a nurse might have a question.
It also sounds like a nurse with some experience and some practical knowledge, which may be very useful in designing an instruction video or some on e-learning to get these informal and formal caregivers going. Because one big finding of our study is that they just feel helpless and not too knowledgeable in practice. But these kind of practical advices may be helpful. About the antibacterial mouthwash, however, I have to warn, because in oral hygiene, the most important thing is just to use fluorides containing toothpaste, and the mechanical brushing is very important. Antibacterial mouth water may introduce overgrowth of bacteria and may not always have the desired effect. So this is not certain that that would be the solution.
I'm conscious of the time, but we've got a couple of hands up in the audience. I'm going to go left first.
Yeah, hi, Michiel.
We'll have to have short answers.
I was wondering if the study showed something on the usage of electrical toothbrush with regards of less hand function, arm function, or in case the caregiver has to brush for the patients.
What use is this, the electrical toothbrush?
Yeah, if the study showed anything about advantages, disadvantages of the use of electrical toothbrushes.
Disadvantage we found is if it's being used improperly, it may induce, if it's used too forcefully, it may induce loss of gingiva, the tooth flesh. So if you use it with care, it may have added value because it ensures greater oral hygiene.
All right, I've got one question over to the right here.
Well, I was just wondering about the same thing because I am using electrical tooth and so I was going to ask about that.
Oh, well, that was good timing.
But also my dentist, she let me use a special toothpaste with extra much fluorine. Is that good or bad?
Dental toothbrush, electrical toothbrush with the last word I missed.
Yes, and my dentist recommended that I use special toothpaste.
Yes.
With extra fluorine. So I have to take it from the pharmacy. It's not bought in the ordinary shops.
Yeah. But I think the dentist gives good advice from this distance. If the special toothbrush is suited to your hand or to ergonomically designed, it may have added value. So I think that should be good advice.
All right, I've just got two more questions. Luckily, it went a bit short, so we've got one here.
Not so much a question. I'm actually trained in dental hygiene, and I studied dental hygiene as my dad had ALS, and I knew a few other people. And so one of the things that we had looked at was different types of toothbrushes, and something with a really small head worked well if you're going to do it manually. But something we really found worked best, and I worked with Philips with this, was using their ultrasonic toothbrushes because they do seem to remove a lot of the plaque in between the teeth. And the newer ones will have a little light at the bottom that tells you whether you're pressing too hard or not. Yeah. And there's also ones with the app, which tell you which areas of the mouth you actually reach. So as a caregiver, it really is a good visual indicator of whether or not you got to all the different places in the mouth. What we also found was, for some people, rinsing their mouth with Biotene first, so they weren't having so much excess saliva, was also a really good thing to do do before you actually start with brushing the teeth.
Amazing. All right, one more, Rachel.
I've been jumping up. Oh, hello. It's more of a comment, really. I just really wanted to thank you because it's the first time oral hygiene has been discussed that I'm aware of in a meeting like this. But also just a kind of an added comment to everybody else's thoughts is that we use a suction catheter with a toothbrush on the end, which can be very helpful for all of the secretions and things. So you can clean and suck at the same time.
I know Nick can probably talk about the. Oh, yeah.
Excuse me. Would that suction with a brush be useful in their home situation?
Yeah. I know Nick, our speech pathologist, talk a lot about oral health and oral hygiene at our clinic, so I think he's pretty happy that this talk was on. So thank you very, very much. I think everyone give it a good round of applause. That was amazing.
Thank you very much.
Look at me keeping people on time. All right, we've got the next one is also pre-recorded. So I would like everyone to welcome David Paul Capel for exploring the uncertainty principle, measuring quality of life with ALS.
In University Malaya Medical Center, and it's my pleasure to present here some work we've been doing recently on the quality of life in people living with ALS. And although it is the stated goal of our MND clinics to improve the quality of life, we sometimes struggle to define what is meant by quality of life. Most importantly, what do people living with ALS mean by quality of life, and what do healthcare professionals mean by quality of life? As for the WHO, what it means is an individual's perception in the context of culture and value systems in relation to their goals, expectations, standards, and concerns. So this goes back a long while to the early days of research, where this diagram came up nicely showing that quality of life can be understood as this gap between, on the top, hopes, ambitions, dreams, and on the bottom, the reality in the here and now. So this graphical show here is on a time scale, on a time axis, and highlighting that it is dynamic. The quality of life can fluctuate within a short period over hours and days. And very importantly, in MND, it will be fluctuating over the course of the disease as well. And not only in a simple single dimension as is shown here, but also very importantly in terms of shifting priorities. And what has been shown before is that the functional status, which is normally used to predict quality of life, does not do so very well in motor neuron disease. And that's because the disease itself is progressive, and hence any measure that equates quality of life with functional status would seem to show that quality of life is only ever decreasing. But intuitively, that does not tally with the observation and the stated quality of life of patients living with ALS, who, when they're asked, will often say that even despite a poor functional status, they do enjoy a reasonable and even very good quality of life sometimes. Beyond that, quality of life is very individual. So what makes impact on quality of life may vary across a broad range. It may be spending time with grandchildren. It may be being able to perform sports. It may be continuing one's professional role, just to name a few. And also, very importantly, horizons shift. And we find this very important whenever discussing things such as artificial nutrition, non-invasive ventilations, where initially it is seen as something that cannot be imagined by people living with ALS as potentially an option. But then as horizons shift, as expectations change, they may often find it acceptable in terms of their quality of life. To just mention, there are many instruments available for measuring quality of life. The WHO own quality of life instrument is the DHOQOL, that is widely translated and validated, but not disease specific. As opposed to that, the schedule for the evaluation of individual quality of life is unique in that it gives patients a place to identify the individual factors that shape their quality of life. But it is not disease-specific to ALS either. And in addition to that, we have two ALS-specific instruments, the ALS AQ40 and the ALS SQL short form, which we actually adapted for our research. The ALS AQ40, as you can see here, does have a selected range of aspects in considerations that are mostly related to functional status in the physical domain, and also, crucially, it contains emotional functioning. And building a bit further on this, perhaps, the ALS SQL short form instrument has been devised around the insight that physical symptoms are one out of a rather large number of aspects that are important. And we can see here the relatively more emphasis posed on the psychosocial and spiritual domains, negative emotion, intimacy, religiosity. So this is a questionnaire that draws on selection from other previously validated questionnaires. And just to briefly mention, the sequel I alluded to just now is focused around a physical cardboard device where patients label the domains important to their individual quality of life on the various sectors in the circle, and then arrange the sectors of the circle in a sliding manner such that the area exposed reflects the relative contribution of this area of their life to the overall quality of life. So it's allowing them to express the weightage of various aspects, and then they will be giving individualized rating of how well is every of those aspects going for them at the moment. So this has been shown in ALS populations to be preferred often over other instruments, because it does give that role for an individual assignment of what matters in terms of quality of life to patients. So building on this, what we did was to use the methodology of cognitive interviewing, which in a nutshell is putting into use the technique of thinking aloud. So in our clinic, we recruited 21 patients and caregivers and used the ALS SQL SF as a questionnaire and handed it to patients with a request to please fill it up, as well as think aloud as they are doing so. For example, if they found a question easy, then just give an answer there. But if, for example, they struggled with anything, then we requested them to please share what is on their mind as they're answering this question. So, for example, if you find something difficult to understand, then you might say, well, I wonder what is meant by this. I think this is meant, and therefore I will answer in such a way. So this is a methodology that has been found useful at the early stages of designing questionnaires previously, and which we chose as a means of investigating how patients interact with questionnaires. And what did we find? First of all, there is this very important issue of the correct understanding of questions. So with cognitive interviewing, we can get an insight into how patients understand questions, how they go about reasoning about their answer, and how they eventually give an answer. So for example, and this is just one example, there's the issue of discomfort versus pain in many questionnaires. And this has been found in our group of patients as well, where sometimes people might say, I don't say I have pain, but I am generally having a lot of discomfort. And this is reflected in the ALS SQL SF in a sense of I'm feeling physically terrible. And a lot of patients can relate to this question well. On the other hand, there are questions pertaining to spirituality that may be challenging and that may at times show a difference between what is the intended aim of a question and what patients actually answer. So, for example, in a Malaysian context, there are a number of patients, quite large number, who do not identify as belonging to one of the monotheistic religions, and yet their concept of religion is often limited to monotheistic religion. So they might say that, well, if I'm asked if religion is a source of strength, I couldn't really answer because I don't consider myself religious, and therefore I would just tick this particular answer. But it clearly may not reflect the intended meaning of the questionnaire in that regard. And likewise, people may wonder, and they did in our study, what does it mean having been a religious person? And they may find coming up with an answer challenging in those cases. Then we found some specific sources of distress that affect quality of life and which are not covered in the existing questionnaires, especially in our group of patients. There is a problem with regards to ALS generally not being a widely known disease in the public, and hence patients struggling with recognition of their disease and isolation from being shunned or sometimes being isolated as the general public has a poor understanding of MND, and out of that there's this awkwardness that arises in interacting with the population, with members of the public, and generally the awareness of MND may be poor. That is a source of distress. And likewise, some of our participants mentioned as an important factor the lack of financial support or the lack of support with regards to their job and employment. And also it emerged that patients often found certain questions inappropriate. And for example, the intimacy domain of questions was often felt as inappropriately asking about physical intimacy. So either patients did not quite construe physical intimacy as issues pertaining to sexuality, or else they might have construed it in that way, and they might have felt that it is inappropriate. And some participants mentioned that they did not think it was an item that would belong in such a questionnaire. And that, of course, has been found in previous research as well, where it has been related by patients that filling up questionnaires about quality of life can be both burdensome in terms of the physical effort and also distressing in terms of the emotional or spiritual aspects. So this is where cognitive interviewing can be helpful in, first of all, finding out whether a particular questionnaire really seems to be acceptable to a population. And why did we choose this title of the uncertainty principle? Basically, like in physics, we have to commit to either determining the location or the momentum of an electron, for example. In measuring quality of life, it does seem that we either have to choose between measuring in the quantitative terms what is the quality of life of someone, or really understanding what is someone's quality of life in a qualitative sense. And patients generally, while answering this questionnaire, did often go into quite lengthy reports about what shapes their quality of life, and they do appreciate being able to express in individual terms what matters to them. And that is something which, on the other hand, the quantitative questionnaires do not allow for. And therefore, the take-home message of this is that there are a lot of useful instruments out already, and when measuring quality of life, or understanding quality of life at the individual level. It is helpful, depending on the cultural background we are in, to use this technique of cognitive interviewing to get an idea of whether a particular questionnaire might or might not work in the setting that we're in, rather than wholesale adopting one questionnaire for all purposes. And with these references, I conclude and thank you for your attention.
Thanks, David. Oh, there he is. Thanks, David. We've got time for some questions. If anybody has a question, put your hand up. Oh, I've got light shining in my eyes. Any questions online? David, it looks like you've absolutely answered all of our questions. And as an OT, quality of life is my jam. So if there's any other...
Couldn't be. There must be some questions. I have a lot of questions myself. I mean, it raised questions for me, but yeah.
Oh, we have a question. Sorry. Just walking the microphone down. It's Gudjon from Iceland.
Thank you for this. But it seems like the government measures our quality of life differently than we do, because they seem to have the measurement of surviving, but we want to be alive and living. So it's maybe we should teach the government to change their measurements of our quality of life. Thank you.
Thank you very much. That's excellent point. And yeah, the reason we were interested in this is that seeing patients doing well quite independently of an ALS-FRS score, we know that it is necessary for research to use ALS-FRS. But I think being in a situation where we only have one multidisciplinary clinic for the whole of the country, we hope that, maybe this could go some way, measuring quality of life and really making it the focus that we should measure, and that we should somehow target in a way that's appropriate for patients.
I've got one question coming in online.
Yeah, we have a question from Lynn from ALS Problem Solvers. The quality of life questions must be especially if the cognitive decline is involved. And so you touched on it a wee bit, but can you expand more on that?
Yes, among the limitations was that our patients were really in the early stages of disease, and that was because of practical considerations and also not wanting to burden them in the setting of the clinic where they had a lot of appointments. I think that is an excellent point to be considered as well, and that I have omitted, and it will probably count as an argument for the individualized quality of life, exploring along those ideas of the sequel, what matters to the patient. And I think that should very well be a focus, even if there is a component of cognitive impairment.
I think that's all the questions. Thank you so much. That was, and I think, as an OT, I look at quality of life in a very, functional way across whatever sort of timeline someone is in, or whatever sort of, place they are. So I think it's something that we all need to look at. Thank you so much, David.
Yeah. Thank you so much for having me. Have a nice day.
Thank you so much.
Look forward to seeing you. Bye-bye.
Now we've got a little bit of time, so you may have seen some Canadian flavoured socks on your table. Now, these are not free-for-alls. So if there's not a couple of pairs of socks on your table, someone has put them in their bag and they need to get them out, because these are going to be earned later in the next session. There might be a little, a little bit of a Canadian flavour to, the future. Anyway, so yes, if there's not a couple of pairs of socks on your table, you need to search someone's bag. And as I said to Sarah earlier, I said to me, my Canadian thing is waffles are really just a vessel to get the maple syrup to my mouth. It's literally like a boat. All right, now we have one of my lovely colleagues from Australia, Elisa Gibb, who is going to present on the cost effectiveness and sustainability of an equipment loan pool for people living with MND, something very close to my heart, from MND New South Wales.
Okay, so thank you for the opportunity to present today. My name's Alicia Gibb and I am from MND New South Wales, and I'm the manager for FlexiQuip, which is our equipment loan pool. Up on the screen you'll see a bit of an overview of what we're going to go through today. I will skip through a little bit of it because it has been repeated over the last couple of days, but I want to have a bit of a different look at things from the angle of environmental sustainability and access to an equipment loan pool. So I'm going to start with some background. So for some of you who may not be aware, MND New South Wales are a service that provide information, support, education and equipment to not just people with MND, but also to their families, friends and carers. And we cover New South Wales and the ACT and the Northern Territory. So to give some context, the combined population of New South Wales and the ACT, or Australia's Capital Territory, in the green is 8.6 million people. And we cover a land size of 800 square kilometres just in the little green section. So this is, by comparison, the same amount of people in all of Switzerland and 20 times the size. Up in the little bit, the yellow at the top, we have 250,000 people, and those people are spread out over 1.25 million square kilometres. So our land size is very large. MND New South Wales have 753 participants over this 12-month period that I've looked at the data. The average age of people accessing our service was 65 years of age. And I won't go into too much detail, but we do have a very different system for people over the age of 65, which is the aged care system, and people under the age of 65, which is the National Disability Insurance Scheme. And unfortunately, what people can access under these two different funding schemes is vastly different. So let's start with what we do know about MND and assistive technology. So we all acknowledge that people with MND will have a change in their function. And there's lots and lots of literature out there that demonstrates that people with a disability will have improved quality of life and independence through access to assistive technology, focusing on their own choices and improving what's important to them. So the progressive nature of MND isn't conducive to waiting months and sometimes even years for funding bodies. And we also face the barriers within Australia, and I'm sure in other parts of the world, where within regional and remote communities, we often don't have therapists that are accessing these areas. So to overcome some of these barriers, MND New South Wales established FlexiQuip. So as I said, FlexiQuip is the equipment loan pool. It's a service that covers New South Wales, the ACT and the Northern Territory. And it was started in 1981 with just 4 manual wheelchairs. And over the years, it's grown as a service, and 10 years ago was rebranded to be called FlexiQuip. So we focus on providing both high and low cost equipment to people with a progressive neurological condition, such with our primary focus being MND. There's also other M&D organisations within Australia that provide some of the largest non-for-profit equipment pools throughout the country. So New South Wales and Victoria being the two biggest services within Australia. So as I said, there are different services throughout Australia and each state offers something slightly different, but the focus is to provide assistive technology to people in a timely manner, to improve quality of life through the use of assistive technology, to meet the high and changing needs, so to be able to swap equipment in and out as people's needs change, and to improve the cost effectiveness and the wait time that we're waiting for funding bodies, and to improve the environmental sustainability by having this hired service model of care. So I'm going to go through some results over at the last financial year in Australia. Our financial year is from the 1st of July 2022 through to the 30th of June this year. So all of the results I'm going to discuss are based on this last 12-month period, and the focus will be on access to assistive technology, quality of life, and environmental sustainability. So as of the 30th of June this year, FlexiEquip had 2,284 pieces of equipment, which were worth over $4 million. The FlexiEquip product range has a primary focus on activities of daily living, with communication and environmental control as well. As you can see in the graph, we have grown very rapidly in the last 3 years. We've grown by 49%, and that's been really important to be able to have equipment readily available to provide to people in a timely manner. So within this review period, within this 12 months, we provided 2,786 items of equipment to 465 different individuals with motor neuron disease. So some of these people had used the equipment longer term and had been using it prior to this financial year and still using it in this period, and 1,840 new pieces of equipment were requested in this period. The equipment needs of people with MND vary greatly between diagnosis and death, and we do know that the phenotype and the rate of progression does have an impact on how much equipment people will access. However, what we found is, on average, people were accessing 8 pieces of equipment, and that ranged anywhere from 1 to 34 pieces of equipment. Interestingly, what we did find is that people under the age of 65 had higher assistive technology needs, on average accessing 13 pieces of equipment through our service, in comparison to people over the age of 65 who are only accessing 8. So now that we have a bit of an idea of the size of the equipment pool that we're talking about, we can have a look at the cost effectiveness. So within the last financial year, of the 2,786 items of equipment, if these had have been individually purchased by people, it would have cost a massive $4.6 million. The majority of our funding is through, the 57% is through charity, bequests, trusts and grants like Fight MND, and that means that 57% of people are not paying anything to access our equipment. The other 43% is still not charging the individual, it's charging to the National Disability Insurance Scheme. So that 43% that's made up in there, we charge a fee of up to $2,500 a quarter to access any of the equipment in the equipment pool, and that's charged to the NDIS, and that accounts for some of the funding, so about $684,000, which we obtained during that 12-month period to help support the program for everybody. And due to the way the aged care funding is, at this point in time, it's not something that we would be charging because there's just not enough money in their packages of care. So like any organisation or program, there's a number of expenses to run an equipment pool of this size. Our largest expense is the wage of the 5 part-time staff members we have, which I won't disclose in this forum. We also have another large expense is the purchase of equipment. Now this varies from year to year and it's largely supported by charitable donations and by grants such as FightMND. I've highlighted our land size just to give some context to this next point. So one of our big costs is our courier cost. Now our land size is huge that we cover and that accounts for nearly $250,000 in delivery fees. To help with bringing down some of these delivery fees, we will be having our own van next year to help with some of the metropolitan deliveries. The next major cost is all of our equipment has to be cleaned, serviced, repaired, and that was around the $73,000 mark. Now that's probably underrepresented here because we have had a large injection of new equipment, so it is lower than it has been in previous years. So as you can see in a very quick snapshot, the costs of what's going out are significantly smaller than the $4.6 million worth of equipment that we've been able to provide. So I'll now move on to the environmental benefits of our program within FlexiQuip. So in a world of fast fashion and single-use items, we don't want disability equipment adding to the landfill. We want to be able to have equipment that meets multiple people's needs and not just a single user. Unfortunately, the type of waste that we can see up on the screen, it's not unique, it's not isolated to Australia, and it is a global problem. We want to be able to repurpose this equipment to have better impacts for people with disabilities and also on the environment. Within FlexiQuip, we are regularly offered donations of equipment. A lot of this equipment is either brand new and has arrived too late through funding bodies or in very near new condition. This last financial year, we were able to accept 125 items of equipment worth $645,000. Now, 58 of these items went into our general equipment pool, and another 67 items, which accounted for $500,000, allowed us to establish what's known as our one-off equipment pool. It's a sub-pool of equipment that's got some very highly specialised devices, and we've been using it as a little bit of a pilot program. So when new equipment comes in, we can trial it through this way with a few users, we get feedback, and then that's helped us to build and expand our pool of equipment. We aren't always able to accept all donations of equipment, so we do have limited storage space, but when we aren't able to accept donations, we'll always look at on donating or recommending other places where the equipment can be used. So just like our mobile phones, unfortunately, equipment doesn't last forever. So there is going to be an element of equipment that needs to be retired. Last financial year, we had 323 items of equipment that were retired due to either wear and tear or becoming obsolete. We were, however, able to repurpose 26 of these items up to the Northern Territory. So we aren't able to provide large equipment to direct participants in the Northern Territory because of the large distance. It's 4,500 kilometres from Sydney to the Northern Territory. So we can't provide the large items. We can provide smaller items that we can post. But what we have been able to do is donate a number, 26 items of equipment, which were primarily wheelchairs and bathroom aids, worth $133,000. That then goes to the statewide equipment service up there, and they repurpose it out to people in rural and remote communities. So the take-home messages from today are that people with MND have high and changing assistive technology needs throughout disease progression. A comprehensive equipment pool, such as FlexiQuip, enables equipment to be interchanged as people's needs change. And an extensive equipment loan library offering hire equipment to people with MND is significantly more cost effective than single-use equipment and environmentally more sustainable. Thank you.
Thank you. As a regular user of the Victorian version, I can say I think you've done, at least as an OT who worked at an MND clinic prior to taking over this role, and certainly with the change in our funding, the MND equipment libraries had to kind of change a few things, and you've done an amazing job of bringing FlexEquip into our new funding world. So thank you very much. It was amazing. Does anyone have any questions? I mean, I think environmentally, we've already had this discussion. We've already, as therapists, we're always talking about the wastage that some of our funding bodies kind of cause. And I know as an OT, we repurpose within our own little OT world that we live in. But go over there, babe.
Hey, Alicia. Susan Bromby. How you going? Great program. And from Tasmania, we also have a very similar program where we are. I did note, though, that your average equipment for NDIS was higher than your aged care, which is very surprising for those who don't know. Alicia pointed out that our NDS participants get a lot more financial funding than over 65, so that was quite surprising to me. Do you have a theory on that?
My theory on that is that the differences between our funding models for over versus under 65 is not just limited to assistive technology. People under the age of 65 have a lot more access to care and being able to be cared in the home for longer. So my personal theory on it is that people over the age of 65 are going into residential aged care facilities sooner, where the equipment's provided. So if we had equitable access to care in the home, I would anticipate the equipment needs being very similar in the age groups.
I would 100% concur with that, because under the Aged Care Act in Australia, the residential aged care services have to provide a certain amount of equipment, and then above that is where FlexEquip or MND Vic would kind of come into that. So, does anyone? Oh, there's a question up back.
Hello, I'm Esther from ALS Switzerland. I don't have a question, but I just wanted to inform that in Switzerland we have a very similar system than you in Australia. And it was very interesting to hear that. And I just wanted to inform you that we have 2 storage rooms, one in the German part of Switzerland and one in the French-speaking part of Switzerland. And I just was interested in your big country, how many storage rooms do you have for your equipment?
We have one primary equipment service. We also store...
That's in just one state,
That's just one state. Okay. That's just in New South Wales. We have one main office, which is in Sydney. We also have a different section where we store our beds from a space point of view, and we've also contracted with a provider in a more regional area of New South Wales, and they hold some of our sub-equipment and will deliver out for us from there.
Okay.
And I think if you put in, I don't know if we can flick back to the Australian map, but where my mum was down in that bottom bit of the turquoise, so about 500 kilometres from the city. And if you go way up north in Western Australia, you know, it's like 18 hours drive. And what the MND WA have done a little bit is like partnered with local equipment suppliers, and Victoria have done that, New South Wales have done that, because just practically speaking, couriering stuff around Australia is impossible.
Where we're sitting in New South Wales, it's about a 10-hour drive up to get to the Queensland border and about 9.5, 10 hours down to get to Victoria.
Incredible. It's really impressive, because our longest drive is about 3 hours.
That's why for us 3 hours is around the corner.
We might not even get out of Sydney traffic in 3 hours.
Thank you.
Does anyone have... Oh, yep, a couple of questions online.
We have a question online from Jackie Hill at the Neurological Support Team. She said, how quickly can you get items such as hoist out which is Hoyer lift. For some other folks, I had to ask what that was, to people. So how quickly can you get the Hoyer lifts out?
So if a person's already known to our service and they're already linked, in metropolitan Sydney, we can get it out within about 48 hours. If it's going up to a more regional areas, it's usually about a week.
Yeah, MND Victoria have similar turnarounds, and even sometimes even quicker if we really need to, because it's person-centred. So it's pretty impressive. Oh, one more question over there.
Thank you for a wonderful presentation, Naomi Fitzgibbon from the Irish Motor Neuron Disease Association. We have a similar bank of equipment, and I'm just wondering, is there any piece of equipment that you don't provide, and if so, why not?
That's something that we don't always provide. Some of the really low-level aids, so built-up cutlery, the lower-cost items, we don't tend to hold as many of those. And it has been a work in progress. I've been with the service for nearly 2 years, and we have expanded quite a lot. Something that we do regularly get asked for that we don't provide is stand-up lifters. There has historically been reasons around that, but that's next on my bucket list to try and tick off and add.
Have you got any OB robot feeders in the FlexEquip now?
We have 6 robotic feeders and one person on a waiting list. My background is in assistive technology and communication equipment, so we do have a lot of eye gazers and iPads, switches, yeah.
She's done a fantastic job of bringing FlexEquip into our new world, so thank you, Alicia, that was amazing. Finally, for this section, and I apologise for probably not pronouncing these very well, even though I have tried, we have a nurse's experience of caring for people with ALS at end of life, a Canadian qualitative study with Stephanie, Miriam and Etienne.
Today we are going to present you the result of our research on nurses' experiences of caring for people with ALS at end of life, a Canadian qualitative study. The teams declare no conflict of interest in connection with this presentation, and if you want more information on the result or the method, you can find it on the hyperlink presented on screen to have the full article. The study objectives were to explore the experiences of nurse caring for people with ALS at the end of life. The study objective came from a clinical problem encountered on the field, and the aim were to have a better understanding of the problematic that nurses encounter in end-of-life care with ALS, and to offer better care for people with ALS at the end of life. The method was a 50-minute interview one-on-one with nurses working in a hospital, home care, or hospices. The participants were a total of 24. 8 came from hospital, 7 from palliative care home, and 9 from home care. Most of them identifying as women in age between 36 and 45. Palliative care home are specific to Quebec. These are community-driven organizations specialized in end-of-life care that resemble hospital long-term care units.
So what did we learn? There were 5 things that we will discuss in the next few minutes. First one, identifying the end of life. Now we're nearing the end. Nurses reported difficulties in the identification of the beginning of the end of life phase. Those difficulties were attributed to the clinical picture, which could vary greatly from one form of the disease to another and from one person to another. Also, the presence of symptoms or treatments associated with imminent end-of-life in patients with other terminal illnesses, such as severe cachexia or dysphagia, or the use of BiPAP on an ongoing basis, sometimes several weeks before death, led to confusion in the identification of the end of life in people with ALS, as one nurse noted. You know, everyone has a different trajectory, no matter what the disease is. But my impression is that the ALS trajectory is different for everyone too. And it's like impossible for me to say, well, there's this much time left or there's that much time left. You know, I mean, there are symptoms that my oncology patients have that make me think they're not going to last long. My ALS patients are the same, but they're not at the end of life. So it expressed very, very well the fact that compared to patients suffering from other diseases, patients living with ALS presented symptoms associated with an imminent end of life, sometimes several weeks or even months before death. Despite those difficulties in the identification of the end of life, some signs were reported by nurses, including respiratory deterioration, increased difficulty in managing bronchial secretion, and the constant need to adjust medication, especially to manage dyspnea and secretion, without being able to reach a new stability. Finally, 4 nurses noted that in retrospect, the novel identification of difficulty digesting enteral nutrition, tube feeding, was the warning sign leading to death, be it in the form of a higher than usual gastric residual volume that persisted, or a reflux of gavage back in the mouth. Those with these signs all died within days of their being identified. Second, teams' communication issues, getting them to express their suffering in ways other than talking. ALS causes significant dysarthria, as you know. By the end of life, many people can no longer use speech, and they can no longer make signs also. This creates major communication challenges. Communication and understanding needs became a major challenge for the healthcare teams, which had an impact on the clinical assessment and support of people living with ALS at the end of life. However, those communication barriers particularly affected psychosocial assessments and related intervention, which left many nurses feeling helpless, as noted one nurse. Well, there's also the psychological side with the person, but there are barriers all the time because of communication problems. You know, what is a good therapeutic approach to take with someone who doesn't communicate 100% verbally? That's what gets complicated too, because you can't understand them. Well, some nurses were happy to just refer them to the social worker or psychologist when there was one available. Others were very involved in this aspect of care because they considered it important. Those nurses were able to develop a comfort with silence and to relate without the need for verbal communication and in order to support their patients. Third things, supporting the need for control. That's what made her feel much safer. Nurses repeatedly mentioned that adhering to a routine was important for many people living with ALS at the end of life and for their relatives too. This strict routine took the form of precise steps in a specific order and using a set technique, all of which we should not be deviated from. While some nurses had this need to maintain the same detailed routine as a rigid requirement without any basis, most nurses it as a means for people to maintain some control in a situation where their autonomy was greatly impaired. The need for control, expressed through a rigid routine, was also reassuring for the care team once they knew the routine, though. a nurse said she was someone who had extremely pre-established routine. So during the day, our partner knew our routine, and that's what made her feel much safer. At the same time, having this kind of routine also made the team feel more secure because since there was a communication issue, it allowed everyone to understand a little more where we were heading. Now to Myriam.
Accompanying a fight culture. Her mind hadn't reached the same stage than her body. This need of control sometimes take a form of desire to maintain care, intervention, and that are no longer appropriate. For example, eating normally in case of severe dysphagia, taking few steps despite the weakness, the severe and the excessive weakness that endanger both the person and the caregiver. That was observed more frequently on people living with ALS than other clientele. We asked the nurses how they explain this very strong desire to maintain these intervention care activities when they are no longer possible or safe. And they reply without hesitation, this is linked to the fight culture. So the fight culture made it more difficult to accompany also the patient with their unrealistic requests because the nurses don't want to be the bearer of the bad news. The fear of being the bearer of the bad news is however, not found on nurses that are more experienced palliative care nurses. So they are more comfortable with the idea of discussing difficult matters or more difficult subjects. So that was found only on nurses that are not experienced nurses. To continue with a verbatim of one of the participants, she said, well, I think that it's a kind of battle she's leading that caused her to grasp onto a great many things. And which means that we can't do what we do with other patients who doesn't have the same condition. The next theme is the extent of the need of care for care, which we will call intensive palliative care. This title was suggested by one of the participants that linking care for person with ELS at the end of life to an intensive palliative care because of the scope of the care that are involved. Even we found that in Maison de Soins Palliatifs, which is a kind of palliative house, there is an unwritten rule that is only one, that we have only one patient with ELS that was admitted at the time. So if another patient with ELS was asking to be admitted in the walls of the maison, and then the file was automatically put aside because we want to protect and maintain the quality of care and also the team, the care team. So we understand that the care needs of people living with ELS is very great. To continue with the verbatim that one of the nurses share, she said the other nurses that was there, she was a regular and she knew very well the patient, had excellent bond with her, to the point that the nurse eventually had to say to the team, listen, I know I'm specialized and so, but right now I could use a break because it's a lot. Yes, because as soon as the patient was on the team, it's going to be a very busy night, evening for sure. If we continue with the 3 recommendations that those team leads to in the study, there is 3 levels of recommendation. The first one is organizational, the second one is research, and the last one is clinical. So for the first one, the organizational recommendation is to adjust the nursing-patient ratio when a person with ELS is in end of life, to maintain the quality of care, In research, we need a better understanding of the hopes, fears, and needs of people living with ELS in the end of life, and explore also the issue faced by other members of the care team, not only nurses. Finally, clinically, we need to develop and adapt an existing tool that facilitate communication and clinical assessment of people living with ELS. In conclusion, we would like to leave that to one of the participants. And she said, I think that yes, it's a terrible disease, but I think that we have the means or the capacity as nurses to do wonderful things with these patients as well. You just have to take the time. Of course, experience help, but we have to take the time. Here is the QR code for the research. And on the behalf of Stephanie, Etienne, and myself, I would like to thank you very much to have listened to this presentation. Have a nice day.
Thank you very much. That was a fantastic talk, and I think having worked in a palliative care unit and worked with an amazing bunch of nurses, it's a very special job that you all do. So we've got a couple of minutes for questions, if anyone has any questions for these guys while they're online. I have a question. In what you called your maison, which is I think like a palliative care unit or a palliative care, which is what we would call a palliative care unit, do your nurses have specific training in caring for some of the special needs of people who are coming to the end of their life after living with MND ALS?
I'll go, Miriam. Well, no, and it's a problem. It was my first project when I graduated this project, and it came from my practice in this home, which we talked about with Etienne at first. And I was there for a few months, and I had a lot of patients, and it was a lot of cancer and how do we say heart disease. And when I had my first ALS, I had not a lot of knowledge, so that was what gave me the idea of this project, because we need to have more knowledge about that.
I think that's a fairly common scenario, certainly in Australia, that what we call palliative care units have all people coming to the end of their life, and it does cause a challenge for the nursing staff to need to have so many skills to work with a wide range of people. I'll just see if there's any other questions. No, you guys did so well. Thank you so much. If there's anything that you'd like to say at the end, hopefully we will hear from you more in the future. But I think there's a lot of fantastic nurses working with people with MND ALS throughout the world. So we all want you to keep it up.
Thank you very much.
Thank you very much.
Thank you.
Well, thank you for having me as your moderator at the end of this afternoon session. I've got a question for Richard. When you come to the next conference, don't forget your thong. He now owes me one Swiss franc. And that was thongs, plural, that you wear on your feet. So we will now have a short break. Thank you for all of you who've been joining virtually. Run away from your computer, go have a snack, have a stretch. For those here in person, go have a stretch, enjoy a snack. There is refreshments out in the foyer again, and we will see you back here at 4:00 for the final section of the day. And there you go, you don't need to listen to me anymore. Thank you.